My name is Payal Parikh. I am the Assistant Dean of Transformation and Integration and Director of the same at the hospital, and I'm also the Interim Chief of Hospitalist Medicine and Vice Chair of Quality and Safety at Rutgers Robert Wood Johnson Medical School. Good morning, everyone. One of the larger impacts on healthcare delivery when it comes to hospitalized patients is a term called length of stay. So length of stay is defined by the hospitalization of a patient from the time that they come in to the time that they leave. And the coming in part can be anywhere from through the ER, through a direct admission from the outside, for example, an outpatient office, or a direct transfer in from a different hospital outside the current hospital. And from the time that the patient steps foot in the hospital for an admission to the time that they actually leave the hospital is the entire length of stay of the patient. Now, the length of stay can vary based on the acuity of the patient, the needs of the patient, but it also can vary in terms of other factors that we will discuss shortly. When we talk about length of stay, it's an incredibly important measure of throughput and efficiency because, generally speaking, the longer a patient stays in a hospital, the longer the time that they actually stay in a hospital bed, the higher the chances of them actually developing hospital complications. So what do I mean by that? Hospital-acquired complications can be anywhere from infection, other infections in the hospital setting. It can be from, being less than ambulatory as they would be in the outpatient setting, if they were outside the hospital. So they are at a higher risk of staying in bed longer and therefore developing bed sores, which could lead to infections. While being hospitalized and while being treated medically, if they have catheters or different sort of what we call central lines, catheters in the body, the longer that they stay, the longer they are at a higher risk of infection. So it has been shown that the higher the length of stay, the number of days in the hospital, the more likely the patients are to get some sort of infection, which we call healthcare associated infections. It has been shown that the longer the length of stay, there is a similar sort of curve to more morbidity and even more mortality, as can be expected that if someone does pick up an infection on top of whatever was brought to them, what brought them to the hospital, they have the propensity to actually have even more complications, which may then end up causing a longer length of stay, or a transfer to the ICU intensive care unit or even death. So the correlations exist that the higher the length of stay, the longer the patient stays in the hospital, the higher the healthcare associated infection risk, such as catheter associated UTIs and central line infections, and also the higher chances of morbidity or mortality. Another impact of length of stay on a patient's inpatient hospital care is, which denotes throughput and efficiency, is actually a measure of their patient satisfaction. So almost every patient gets a survey once they're discharged from the hospital on the care that was provided to them by all care team members. And the longer that a patient stays in the hospital, there is a direct correlation to their patient satisfaction scores. Generally speaking, there is a target length of stay, number of days based on complexity of a patient. But when that length of stay days is higher or longer than that is expected for what brought them into the hospital, then what that can do is actually lead to downstream effects of the healthcare associated infections, morbidity, mortality, but also patient satisfaction scores suffer as well. Patients are not happy when they have to stay in a hospital, rightfully so, when they actually can be discharged to home. Now, there are many reasons why this could happen. One of the reasons is that maybe they're deconditioned from the actual hospitalization and they aren't moving around as much as they could be, as if they were outside the hospital. It has been shown that every day that somebody stays in a hospital bed and is not actively moving, every day you lose 30% of your muscle mass. So the longer somebody stays in a hospital, the more deconditioned they can be, and therefore the more therapy they will need to get back on their feet. Many patients that are here for longer length of stays often, in fact, do need to be discharged to a rehab facility to get their strength up. Now, when we talk about discharges to what we call next site of care, so not someone who's going home, but really going to a facility, there's a lot that goes into that conversation. Um, Bed availability at different facilities, authorizations for insurances for those specific facilities, and then the actual transport and timing of actually being able to get the patient there. So those in and of themselves may actually also increase length of stay. So overall, we want to reduce the time that the patient stays in the hospital to match whatever diagnosis brought them into the hospital. So for example, if somebody came in for a certain diagnosis that would keep them in the hospital for 3 days, and we discharge them in 2 or 3 days, then that would positively impact our patient satisfaction and would keep the patient safe, and likely the patient would be able to go back home. If, however, that same patient that should have been in the hospital for 3 days is now actually here for 7 days, the downstream effects are that there could be a chance of those infections, morbidity, potentially mortality. If they do go home, it could impact their patient satisfaction scores that they actually ended up staying 7 more days, and there's downstream financial implications of that. And as well, that they may not even be able to go home right away because they've been here 4 additional days where they may have been deconditioned. So a way to counteract all of that is to really try to get our patients out of the hospital safely when their initial presenting complaint is resolved and there's no other complications to address. And multiple things sort of play into that. We need to make sure that we are efficient in our healthcare delivery. So what does that mean? So our testing and our cardiology, radiology reads, our procedures, everything are done in a timely manner so that we don't have delays that then delay the length of stay days for those procedures to be completed, after which the patient can be discharged. So really augmenting the efficiency of our studies and our procedures is one way. Augmenting our ability to get our patients out of bed to counteract that 30% reduction in muscle mass per day that is a known fact. So ways to think about how can we actually get our patients walking around safely when safe to do so, when their acute medical need is taken care of, exercises in bed, of course, more resources from physical therapy, support staff, occupational therapy, so as to then avoid the downstream effect of patients needing to actually go to a rehab facility, and maybe we can get them faster to home. It has been shown that the length of stay that a patient stays in the hospital is shorter for the same diagnosis when a patient is actually going home as compared to a rehab or a long-term care facility. We often think about length of stay as not only a measure of efficiency, but throughput. So when a patient is in a bed in a hospital, that patient is occupying a hospital bed. And what does that do? If the patient, again, is meant to be there for 3 days and the patient is discharged in 2 days, then another patient can come in and occupy that bed. If, however, that same patient is meant to be there for 3 days and then is actually there for longer, 4, 5, 6, 7 days, then that additional 4 days that that patient is occupying the hospital bed, that's 4 days less another patient or other patients can actually get into that hospital bed. So what does that mean? The hospital is one where we continue to take patients because they are in need. So that leads to increases in our hospital occupancy. And it has been shown that there's a pivotal point where if a hospital is past a certain percentage of hospital occupancy, it actually does lead to downstream delays in efficiency in those same procedures and those same radiology reads. and same radiology studies, just because it overwhelms the capacity of the staff and the machine to be able to get to all the patients. So having a patient stay in the hospital longer than is intended for their medical management, for their needs, does have downstream effects on increase in the hospital's occupancy, and subsequently, this leads to downstream further increases in length of stays for patients in the hospital because the operational efficiency is declined. Patients will come to the ER. The ER does not close its doors. And so as the patients in the hospital beds are being occupied, those that are admitted in the ER are actually also then staying longer in the ER. So for that example, again, if a patient in a hospital bed is discharged at the 3-day mark, then the patient in the ER has just come in may be able to go upstairs to that hospital bed and not stay in the ER. This allows for much more robust care on a floor, which is dedicated to that patient's needs, but also improves our patient satisfaction scores because the patient is not sitting in the ER more than they need to when they are admitted. However, in that same scenario, if that patient that is admitted and should have been there for 3 days is now there for 7 days, then patients in the ER that only should be there for a day, once admitted or less, they actually are sitting in the ER for 3 or 4 days. So as you can imagine, that then causes downstream effects of poor patient satisfaction because they are in an ER, sometimes in a hallway, and they're not able to get the privacy that they need. They are not making it up to the specialty floor that they need. So while the doctors and nurses are caring for these patients, they do not get the robust care that they would get on an inpatient medical floor. So length of stay is an incredible important metric when it comes to improving our healthcare delivery. Aside from patient satisfaction, patient safety when it comes to hospital-acquired infections, and as we discussed, aside from morbidity and mortality from long length of stay and deconditioning that happens from long length of stay, there are also financial implications. So if a patient is deemed to stay a certain number of days based on their medical diagnosis, and then they actually stay longer than that, then their insurances may actually not allow payment to be given for those extra days that the patient stays. And so that hospital actually may not be reimbursed, and there are often penalties associated with length of stay days that the patient that was above and beyond what the patient should have been as their metric for length of stay. So this is all a balancing act. It is a very, very important concept to sort of work through. And as I've highlighted, there are multiple nuances at each step of the way when we think about a person's length of stay. So it is a true balancing act, balancing the medical management, which of course is our utmost priority for the patient when they're hospitalized, balancing their safe discharge plan out of the hospital once the acute medical issue and any complications are taken care of. But we also need to keep in mind the care coordination aspects and how do we prioritize our staff and support staff when it comes to physical therapy and occupational therapy and nutrition, when it comes to the radiology studies and the echocardiograms and prioritizing their reads, when it comes to procedures, what should be done inpatient and what should be done on the outpatient setting. We can use and leverage AI, we can use and leverage technology to assist us with this as we sort of map a patient flow in the hospital from admission to discharge and every input that comes in as we provide the safe healthcare delivery we strive to provide. Thank you for listening. I look forward to working with you.